Good evening, ladies. This will be our third case study via YouTube as requested. And this one I'm doing from home, so you'll have to excuse me if a child runs through or something crazy happens or something catches on fire. I do have 3 boys, and you guys know there's always something happening here that in my life that is extreme chaos. So I'm just going to throw out that disclaimer, and we'll just get going on our third case study. So today, this was a patient of mine, and it was a good friend of mine. He was my patient for years, and he passed away just about a year ago. So actually, instead of talking about a patient that we have as an inpatient at the hospital right now, we're going to talk about a patient that I had for years, and kind of go through his disease process and break down his primary medical history, and talk about some of the challenges he faced, and talk about the volumes and capacities of his lungs, and diagnostic things that we found with him, pretty much just his whole pulmonary picture. So let's get started on this case study. And I don't have as big of a whiteboard at home, but I do have one, because what I have done is put my kids' school work on a chart, like when they were kids, and they were not happy about that. So I do have a whiteboard, and you know that I wouldn't know what to do without my whiteboard. So we'll get started with our S-bar. So here we have, this patient is a 66, I hope you guys can see that. He's a 66-year-old male. He was admitted for hypoxic respiratory failure, and he, at this point of his last admission, he was a DNR, DNI. His background consisted of idiopathic pulmonary fibrosis, and we're going to talk quite a bit about this with this case study we're doing about restrictive lung disease. He had severe pulmonary hypertension, and he had regular hypertension. He had congestive heart failure with what they call heart failure with reduced ejection fraction, hyperlipidemia, and he did have obstructive sleep apnea as well. So in your mind, you're thinking, wow, 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 and wow. On admission of his last hospitalization, he was 78% on 12 liters per minute of high flow oxygen through a nasal cannula, so just a high flow nasal cannula. And this was his home setting. This is what he used on his liquid oxygen portable. So he comes into our emergency room. He's 78% on 12 liters per minute. His heart rate's 130. His respiratory rate is 34. This is his ABG once they got him to the floor, and we'll kind of talk about that a little bit. So you can see here his, and this was on 60% oxygen once they got him kind of on a V60, a different modality for oxygen delivery. His pH was 7.46, his PaCO2 was 36, his PaO2 was 62.6. I'm sorry, you can't really see the decimal there. That's not 626. 626, it's 62.6. And then his bicarb was 25.4 with a 90% saturation. So there's some calculations we can do on like his A to A gradient, his P to F gradient, and we know pretty right offhand that this is a fairly low PaO2, and that's a fairly high FiO2. So we know he's in hypoxic respiratory failure, that we know from the beginning. So a little bit more about this sweet gentleman, and I've kind of got this written out in a Word document that I'll email to you guys also. So quick, I'm going to show you his chest film, his admission chest film. So that is his admission chest film. You can look at that and kind of see a lot of things that are definitely huge triggers, and immediately we start thinking, wow, There's very little gas exchange. There's not much as far as air anywhere in there. And they call this a ground glass appearance, and that's exactly what we're seeing from this chest x-ray on here. So that's an anterior to posterior film. It's not very rotated. His trachea is midline, but he definitely, and I apologize for cutting this off over here, regardless, his costophrenic angle is not easy to see over there, so that's pretty tricky from the very beginning. So that's his admission x-ray for this admission that he was in. And so if you look up idiopathic pulmonary fibrosis and you see kind of do a little bit of a review of chest films for that disease state, you're going to see a lot of chest films very similar to that. I also have a slice, and this is pretty far down. You can see his entire, so I have a slice from his CT scan. So looking at that CT scan, it is a contrast CT. So some of this whiteness you're seeing is the contrast in the vasculature, but the majority of this is that fibrosis in the lungs, and so it's just a real. This is called honeycombing, and it's quite a depiction of the amount of fibrosis that this patient had in his lungs. It's a very definitive slide talking just that cross section of that lung area where you can see areas of there's a big area of air. And so that's a single area of air. Here's a big area of air without any vasculature around it. And here's one over here. They call that honeycombing. And if you think about how hypoxic he was on admission, you can kind of look at this and see, and you start thinking about why is he so hypoxic, and then you think about the diffusion of gases into this, or the ventilation to perfusion mismatch that this patient's having, knowing that all of this is fibrotic lung, and it's just this is very alarming. The best thing you can do is look at a normal chest CT and then look through something like this, or look at, you can even Google chest CTs for pulmonary fibrosis patients, and classic, it's this honeycomb effect is what they call it. So there's kind of just a little bit of a little blurb on his admission. So we know he's extremely tachycardic, he's extremely dyspneic, he's tachypnic, and he's hypoxic. So he comes in and he's a DNR-DNI. So you guys are talking about initiating ventilation with the V60 right now, and I sent you guys another YouTube video that I watched last night, and it was a great YouTube video on just how to set up the V60, because I know you guys aren't having that lab time that you really need at this point. So if you're thinking about what are you going to do, so this patient presents to your emergency room, and they send him straight up to the ICU. You've got this blood gas, so his pH was 7.46, so just real borderline alkalotic. We're not worried about it. The reason is his pH is 36, so he's not having hypercapnic respiratory failure, he's having hypoxic respiratory failure. His PaO2 is only 62.6 on that 60% FiO2. So we know that he definitely has a VQ mismatch, and we definitely need to assist with his oxygenation. So when you're initiating the V60, some things that you need to think about. So is this patient we need to think, we talked a lot about, is your patient having an oxygenation issue, or is your patient having a ventilation issue? And sometimes oxygenation issues and ventilation issues come together, and sometimes they're very much separate. And we kind of have to think about the pathology and what got our patient to us, so we can start to kind of work backwards from that to assist them and help them with, getting them treated for what they were admitted for. So this patient's background includes idiopathic pulmonary fibrosis, and he's had multiple admissions for similar things like this. So we all know that when he came in, that this was going to be something that we had to contend with, and that it was probably what brought him in. And how his problem list plays together, we also kind of talked about that in our last case study, that he's got this, I'll bring this up here and we can kind of talk about. So he's got the idiopathic pulmonary fibrosis. He has that severe pulmonary hypertension, regular hypertension, this time congestive heart failure rather than the cor pulmonale that we saw in the last one. He has hyperlipidemia. We're not overly worried about that. That probably doesn't come into play, but this very much does. This very much does. This very much does come into play for this hospitalization. So if we think about this idiopathic pulmonary fibrosis along with this severe pulmonary hypertension, and we talked about last week with our patient where the severe pulmonary hypertension can lead to right-sided heart failure. I actually did not get his most recent echo, and I will get that information and get that over to you guys via email or text on what his right side heart pressures and if he had any right-sided heart failure. But I suspect, with the severe pulmonary hypertension, that he indeed maybe has some right heart failure along with the left heart failure. So we know this congestive heart failure with a reduced ejection fraction is that left ventricle. So we know that he has that deficiency already. We suspect that with the severe pulmonary hypertension that he has some right-sided heart issues as well. So if we're thinking about from a pulmonary standpoint and how closely the lungs work with the heart, we know from the very beginning that this patient's going to be having some issues. So we need to start thinking along the lines of how are we going to help this patient. And we talked a little bit last week about when we're thinking about when do we initiate non-invasive ventilation? Is it indicated, and what makes you think that non-invasive ventilation may be indicated? So we talked about, does this patient have an ugly ABG? Well, we look back at his ABG and it's fairly close to normal. The majority of his parameters are within normal limits except his hypoxemia on that high FiO2. So we do know that I scratched my face at home because I'm making hand sanitizer over there. It's my chemistry project right over there. I'm making some hand sanitizer. So I can scratch my face at my house. Okay, I'm sorry, I'm very, squirrel. Okay, so I don't even know what I was talking about. Let's get back to the fact that his ABG is pretty much normal except his oxygenation, and we're going back to that. Does our patient have an oxygenation or a ventilation issue? We know he has an oxygenation issue, knowing that we could also see a ventilation issue where he could, he's going to poop out over time. His work of breathing is obviously very high because he has this respiratory rate of 34, heart rate of 130, and he's just super hypoxic, so your body just doesn't do that for very long. He's definitely going to have a ventilation issue if we prolong initiating treatment for what he's got going on. So what are some things we think about before we initiate non-invasive ventilation? Okay, do we have an ugly ABG? Well, we have hypoxemia, and that means, we kind of do have an ugly ABG. And 2, what is our work of breathing? Is there any way we can assist this patient to unload some of that work of breathing off of him? So let's talk about his problem list and his presentation and see if we can indeed assist with this. So what do you guys think so far? We think with pulmonary fibrosis, and we're talking primarily today about a restrictive lung disease. And so relatively speaking, a restrictive lung disease is a process, either chronic or acute, where the lung is just not able to expand normally. Wikipedia says, let me read to you what Wikipedia says. Restrictive lung disease are a category of pulmonary, pleural, or parenchymal respiratory diseases that restrict lung expansion, resulting in decreased lung volume and an increased work of breathing and inadequate ventilation and or oxygenation. So we're seeing this as a presentation, and it very much fits the mold for our patient that we're dealing with. So we have to consider the restrictive lung disease for him. And we can talk about the different kinds of restrictive lung diseases, I guess, if we want to work from the outside in. So you think about the thoracic wall cavity, the chest cavity as being, that can also, the musculoskeletal system around the lungs can also be part of causing that restrictive lung disorder, in that maybe it's not expanding as well. So if you have a kyphosis or a scoliosis, and a fusion, a vertebral fusion, or any kind of fusion where maybe your accessory muscles aren't able to, your rib cage isn't able to expand how it normally would, and you're not able to utilize your intercostal muscles and your accessory muscles for normal breathing, really, then that's going to cause all of the work of breathing you're going to rely solely kind of on that diaphragmatic breathing, and that usually is sufficient for when you're at rest, but when you get up and your oxygen demands go up and you need to take a deeper breath and bring in more oxygen. So your body's requiring more oxygen, your muscles and tissues are requiring that oxygen because you're exerting yourself. That diaphragmatic breathing isn't going to be able to keep up. So you will have shortness of breath associated with exertion and also hypoxemia, and we'll kind of talk about why with that. So if we're working from the outside in with a restrictive lung disease, we kind of think about the first thing that could cause the restrictive lung disease could very well be the rib cage or the muscular skeletal system. However you really want to say that with that lung expansion, it can be confined with, or just there's a lot of things that can keep that rib cage from allowing you to utilize your accessory muscles for respiration. So that's kind of your extrapulmonary part of Wikipedia's little definition of restrictive lung disease. Pleural, so the pleural cavity, you think about that, you're like, well, how could that cause a restrictive lung disease? And if you think about the pleural space is the space between your rib cage or your musculoskeletal system of the thoracic cavity and your lungs, there is potential for space in there between that visceral pleura and the parietal pleura. So you think about if that space gets full, you only have so much space in there. Your chest wall doesn't get a whole lot bigger when you inhale. There's not a lot of room for expansion. And if you get something in there, whether it be blood from a hemopneumothorax or pleural fluid from a pleural effusion, air from a pneumothorax, you start thinking about how that space fills up. So if that space fills up, your chest wall can't expand to make room for whatever is in your pleural space. So instead it's going to force your lungs to kind of be consolidated and not be able to expand how they are. So you can have a restrictive lung disease from having an empyema, which is an infection of that area, or a chronic empyema, or it's sometimes they go in there and they have to do some, they call it a pleurodesis, and that can change how that area, it allows for lung expansion. So really anything that's in the pleural space that's not allowing the lungs to fully expand can cause kind of a restrictive lung disease. And then, so we've gone from musculoskeletal to the pleural space, and now we talk about in the lungs. And a lot of the restrictive lung disease stuff that comes from in the lungs, and Wikipedia called it let's see, parenchymal respiratory stuff. So if you think about the parenchymal diseases, they're talking kind of about a disease of the interstitial space, so the alveoli, where the gas exchange takes place, so inside of the lungs. So we've gone from thoracic cavity to pleural space to now we're actually inside the lungs with this restrictive component. And we talked a little bit about that interstitial space for a couple of things that we went over earlier in this semester. So your interstitial space, your alveoli is the air sac where the air goes down. So your lungs are like an upside down thing of grapes. And had I got those at the store today, we could use them as a prop, but I did not. So anyway, an upside down thing of grapes where you know what the alveoli are. And so the interstitial space is that space between the alveoli and the blood vessel that wraps around, so your pulmonary vasculature. So there's a space between the air sac where the oxygen comes in and the blood vessel that perfuses those alveoli and expels the CO2. So where all of your gas exchange takes place. So when they call something like pulmonary fibrosis, or this patient IPF, idiopathic pulmonary fibrosis, a lot of times it goes hand in hand with this interstitial lung disease. And if they don't quite know, or they don't have a definitive answer of why or what this patient was exposed to or what happened to cause this interstitial thickening, then we call it an idiopathic, so IPF or idiopathic pulmonary fibrosis, or we do a lot of times lump those kind of together as an interstitial lung disease. And so we're talking about inside the lung, and if that area is thickened or fibrotic, it's just exactly how it sounds. What happens is that alveoli isn't able to expand the way that it normally would, because that fibrotic area, that interstitial area is fibrotic, and it just doesn't allow for that alveoli to expand how it normally would. So you can think about it's kind of a twofold issue that we have with that. So we have that alveoli that isn't able to expand how it should, and then we have that thickened interstitial space between that alveoli and that vasculature, so we know that our gas exchange is also inhibited. So we talk about pulmonary function tests for these patients, and if you think about it, the three things that pulmonary function, we can use our little whiteboard. So the three things that our pulmonary function tests measure, so diagnostics, I even wrote it on here, diagnostics, so we talk about airflow, and we talk about some sort of bug flying around. Airflow, we talk about volumes, and we talk about diffusion. So what do we think about, this is really kind of difficult to do. I really need my big board. I should have done this at work. Anyway, too much going on at work. Diffusion, so we're talking about an increased or a thickened interstitial space. Woo! So with that being said, we know that our diffusion is going to be low. So anytime that you have a thickened area between your alveoli and the vasculature, you know that you're going to have an increase in diffusion, or I'm sorry, a decrease in diffusion capacity. So your body's ability to diffuse your gases into and out of the bloodstream are going to be inhibited if that layer between them is thickened. So we know all about that. We've done that before. So let's talk about spirometry. So you think about the airflow for these patients, and the compliance of their lungs is low. We know that if you can't expand your lungs for one reason or the other, or one of the three reasons we kind of talked about working our way in, you know that your volumes are likely going to be low. But let's talk about airflow. So what I kind of I guess probably the easiest way to think about it is that, and I just wrote this down because I didn't want to confuse you guys or mess you up, and so I'm going to send this to you. But it says restrictive disorders, or a disorder where your compliance is low and your chest wall is not able to expand, or your lungs are fibrotic, or you have something in your pleural space that's not allowing your lungs to expand. Restrictive disorders have near normal or higher than normal FEV1 over FVC. So let's stop and think about that. So FEV1 is your forced expiratory volume in 1 second. So you have a near normal or higher than normal FEV1 over FVC, so over your forced vital capacity. But here's why, and it's because both the FEV1 and the forced vital capacity are typically reduced proportionally. So that number, so normal lungs, you should be able to expel about 70% of all of your air that you can expel, so all of your forced vital capacity, you should be able to expel 70% of it in 1 second. So I hope I'm not confusing you with these weird numbers around, but you think about your forced vital capacity, so all that you can blow out. You should be able to blow about 70% of that out in 1 second. So a normal FEV1 over FVC is 70%. So sometimes these patients will have a little bit higher FEV1 over FVC because both the FEV1 and the FVC are reduced proportionally. So if you see some pulmonary function tests and you're not quite sure how to interpret those, where you're like, why is that higher than normal? So you think you have to compare all of the things, of course. So we want to look at our spirometry volumes and diffusion. So we already know our diffusion's low. We talked about why that's the case. We have that VQ mismatch with that in that thickened interstitial area, or that fibrotic lung that just isn't able to diffuse through that thickened fibrotic tissue. And so we know our spirometry, our FEV1 over FVC can be higher than normal or normal. Based on that, but we have to look at their percents of predicted for this patient and see if they're reduced proportionally. And so then we know volumes. So think about what our lung volumes would be, and actually Wikipedia told us already kind of what to expect from that, but they did tell us that, let's see, how did Wikipedia say that? They say resulting in decreased lung volume. So pretty much on a restrictive lung disorder, you're going to see that all of your volumes are low. So we're talking about a normal or sometimes a high FEV1 over FVC, but both are reduced proportionally. So we will have a little bit less than predicted FEV1 and FVC. So our flows are going to be lower, but our FEV1, FVC may be normal or high. So keep that in mind for these restrictive lung disorders. So that's our airflow or our spirometry. Our volumes are such that we know that they are all decreased. You can't expand your lung. You're not going to be able to get those volumes in there. And then our diffusion, we know that's also decreased. So those are kind of some telltale signs as far as pulmonary function tests for these patients that have this restrictive lung disease. So we've kind of talked about when we saw what x-rays look like. You just have that diffuse ground glass appearance, the chest film where you have that honeycombing, those areas. And it's really interesting, and Google is a great resource for this. I've used it for years and years. Just, you just like, what a normal chest film looks like. So you just go on and you Google chest films for patients, or chest x-ray for patient with interstitial lung disease, or chest film with patient with idiopathic pulmonary fibrosis or something like that. And it gives you a lot of, and it'll give you a breakdown of kind of what you're looking at and what you're looking for. And then you start to understand that why your diffusion is so terrible, because you can just see all of those areas where that fibrotic tissue is, and that causes for that increased or very decreased, diffusion capacity. So on assessment of this patient, what do you think are some physical findings we're going to find? So our patient is chronically hypoxemic. His home oxygen regimen is as 10 to 15 liters a minute continuous. So we know with chronic hypoxemia, a lot of times we'll see clubbing. So a lot of these patients at end stage interstitial lung disease or restrictive lung disorders will have clubbing due to this chronic hypoxemia. Crackles. So you think about how the lung tissue, how those alveoli are there. It's very hard to expand those alveoli, but they're easy to close because their compliance is their lung compliance is very poor. So they're gonna it's hard to open them, and they're gonna shut a lot. And you'll talk and learn a lot about shear forces and those kind of things that we deal with these patients next semester. But a lot of crackles. So when this patient came in, he had crackles all the way up his back, inspiratory crackles, and he had some bronchi. He does have secretions, and he has a couple of other things going on too that are not in his favor. So that was part of that. And so we talked about his chest film. We talked about his restrictive lung disorder. We talked about his ABG. We talked about everything. Now let's talk about, and I do have specifically his PFTs. So his FEV1 over FVC was 105% of predicted. So you think about that, but actually his FEV1 was 68% of predicted, and his FVC was 63% of predicted. So there we're having that proportionally lower of those two flows. His lung volumes, his expiratory residual volume was 64%. His ERV was, his residual volume was 50% of predicted, and we'll just talk about that. His total lung capacity was 58% of predicted, and his diffusion corrected for alveolar ventilation was 51% of predicted. So those are his. Also, so we think about treatment for this patient when he comes in. So they're going to put him on high-dose steroids. Our bronchodilator is going to be indicated? Probably not. He came in they put him on antibiotics and high-dose steroids, hoping to help with any of that inflammatory process that might be happening. So we're thinking mostly about unloading that work of breathing off of him and oxygenating him. And so if you have a patient that's got a SAT of 90 on 60%, you do know that you probably want to give them a little bit of assistance. So what part of our ventilation, so we're talking about bilevel ventilation, so we're going to initiate ventilation on him, and this was done right when they got him up to the ICU, just to primarily unload that work of breathing and to help with oxygenation. So you think about settings for these patients. So we're going to set 2 levels on our, and we won't talk about rates or spontaneous time or any of those kind of things. We'll just talk about how his lung compliance, how we can ventilate this specific patient with his lung compliance. So like some critical thinking things. We already know the compliance of his lungs is not good because of he's got a restrictive lung disorder. We think about his airflow with his PFTs. It's low, but it's proportionally low with his FVC, but we have to think about his inspiratory to expiratory time, okay? We think about our volumes with our PFTs. If we're working on oxygenation, we want to add EPAP or CPAP or whatever we need for that bottom pressure for oxygenation, right? So we think about how is that going to affect, how are we going to adequately give him enough EPAP or CPAP or PEEP in his lungs to help splint open those airways when they're fibrotic. And so you kind of have to start thinking about what PEEP level or EPAP level can I give him without causing damage to help assist with oxygenation in this patient. So essentially we want to splint open those alveoli, but we have to think about the fact that it's not a typical lung area where that interstitial space around there is fibrotic or hardened and thickened. And so we're working against a different force than if we have atelectasis or we're trying to recruit lung through that kind of stuff. So we think about that bottom pressure, and we're trying to help with his oxygenation. And we know that the IPAP is generally for ventilation, and the EPAP, we focus a lot on that with the oxygenation. So we have to pick a pressure and just kind of see how we do, because we're on the V60. Luckily, we're able to dial up our FiO2. We're on, we're hooked into the high pressure oxygen, so we're able to dial in our FiO2. And we want to give him enough PEEP that it helps to splint open those airways and to get that oxygen that we're giving him down into there. But we have to be really careful with that we're not going to cause any barotrauma or issues with those hardened alveoli. Okay, so we're thinking about that when we're setting our PEEP, EPAP, or CPAP level. Our bi-level, so we're going to talk about our IPAP. So this patient came in and his respiratory rate was 34. It's probably for a number of reasons. One, he's hypoxic, right? So that's why he's tachycardic and that's why he's tachypnic. But he's not able to get enough of a tidal volume. He's demanding, his body wants much more oxygen and it wants a little bit higher of a tidal volume to help ventilate. And he's not able to do that. He's not able to overcome that work of breathing. So we're kind of going to do that for him. So if we're thinking about our delta P and we want a tidal volume like 7 milliliters per kilogram for this patient, let's say we want a tidal volume of 550. So that would be normal for him. And what are we going to have to think about? So a critical thinking tip is, are we going to have more or less pressure support in a patient with a restrictive lung disease in order to get them that tidal volume we're looking for? So if you're putting me on non-invasive ventilation and I do not have a restrictive lung disease, are you going to need a higher or a lower delta P to ventilate me versus somebody that has those low compliance lungs? So that's kind of your thinking for the day is, I've got a patient with low compliance lungs. They're not able to expand the way normal lungs do. So we're going to have to increase our delta P in order to ventilate this patient. What we also have to consider is our I time to E time. These patients probably need a little bit more inspiratory time because the recoil of their lungs is fairly strong and they don't have issues with exhalation like our obstructive lung disease patients do. So we got to think about flows and pressures, and we're going to require a little bit higher pressures on our inspiratory pressure to be able to therapeutically ventilate this patient with a tidal volume that's appropriate for their lung condition or for their work of breathing. So what we're going to do is we're going to get a CPAP pressure where we feel comfortable with, and generally you just kind of start at 5 and you can titrate that up a little bit until you feel like it's a good splinting. Oxygenation is kind of baseline for this patient without causing barotrauma. We know we're hypoxic regardless at baseline, so there's only so much we can do. So we want to set that EPAP level to where we feel comfortable that we're able to splint open those airways and alveoli, and then start titrating up that IPAP so we get a therapeutic tidal volume, knowing that our delta P is probably going to have to be a little bit higher because it's going to take a little bit more pressure to get more volume into these lungs that are kind of stiff. And I hope I'm not confusing you guys with this, but that's kind of how we have to think about these patients with that restrictive lung disease. So when you're just thinking about your patient coming in and knowing that you're just going to have to help them with that work of breathing, he's at very high work of breathing, we know immediately you're going to put him on with a fairly high FiO2 to start, because first things we need to do is, preserve their organ function. And we know that when they're hypoxic for long periods of time, it's really hard on the heart. This patient already has congestive heart failure, so his left ventricle's already, his ejection fraction's poor, and we know that can also back up into the lungs when we have a poor ejection fraction. We know he has pulmonary hypertension, so we know that can also cause stress on that right side of the heart. And so we already have enough stress on the heart just from baseline things off his problem list. We don't need to add, and the hypoxemia probably caused those things, but we need to alleviate that the best we can. And so what we want to do, set our CPAP to a therapeutic level, what we think is okay, a lot of FiO2 to start, and then we want to start titrating up that IPAP till we overcome that work of breathing. We've got to slow his rate down. He's breathing at 34 times a minute. So if you think about that, that's less than 2 seconds for every breath he's taking. So we want to set, so our I time is a fair amount of the total time. So our I to E ratio, we may do a 1-to-1 for this patient for a bit, just to help with lung expansion with him, and oxygenation, and then we can start titrating our FiO2 down. We can increase our EPAP as we need to. First thing we need to do is overcome that work of breathing, because he has a very high work of breathing. So I hope that made a little bit of sense. So if you think about that from a bi-level ventilation standpoint, we know that we have to get enough EPAP in there to splint open those alveoli, and then we start working with our IPAP till we start alleviating some of that work of breathing. So a normal tidal volume for this patient's probably around fairly tall gentleman, and I actually need to start thinking about having you guys figure out what an ideal tidal volume for this patient would be, probably somewhere around 600 to 700 milliliters, and he probably hasn't seen that in a long time with those kind of lung function tests and that looking at that chest film and that CT. So, but we do need to realize that we may not get ideal tidal volume on him, and we're okay with that because our ABG isn't that ugly, if you will, at the beginning. But what we have to do is help him overcome that work of breathing. So we're going to increase that delta P until we overcome that work of breathing, knowing that this patient's delta P may be a little bit bigger because it's gonna take more pressure to get an adequate volume in there for these patients with restrictive lung disease. So I hope I didn't confuse you. I'm actually just going to send you a Word document that I have here, and I'll also send you I found a few extra different chest films and a few different CT scans for patients with this similar disorder. His are they're very representative of what you will see in most of these patients, and so, excuse me, if you have any questions, let me know. You will see these patients come in with hypoxic and hypercapnic respiratory failure, just because their respiratory muscle weakness and their work of breathing is just more than they could do, and they start to poop out, and then that CO2 starts to climb, and they do get acidotic. He's a borderline alkalotic, but he's hyperventilating. You can see that with that high respiratory rate. So you will see these patients come in combined respiratory failure. They'll have hypercapnia, and they'll also have hypoxemia, and you'll see them come in with just this hypoxic respiratory failure. And so you can have a combination of things happening, but essentially what you kind of have to do is break it down from the outside in, look at their problem list, know what you're dealing with, and help them to overcome that work of breathing. So if you guys have any questions, let me know. I hope you have a good night.